Welcome to Healthcare Update with Leila Kramer. Each episode brings you informed commentary on the most recent issues in healthcare and public health, as well as in-depth interviews with prominent experts. And now, here is your host, Leila Kramer.
Hello, I'm Leila Kramer, Executive Producer for the National Library of Patient Rights and Advocacy. Many changes have taken place in the past 12 months in our American healthcare system and our public health system. Every day, we hear on the news about the future of medicine and how things like artificial intelligence could impact the practice of medicine. Today, my guest is Dr. Wayne Bond Lau, Professor and Associate Dean for the Office of Student Affairs at the Sidney Kimmel College of Medicine, part of Thomas Jefferson University. Dr. Lau is also Director of the Jefferson China Center and Associate Director of the Jefferson Japan Center. Dr. Lau attended Jefferson Medical College and was Chief Resident in Emergency Medicine at Jefferson University Hospital, and still practices as an emergency medicine physician. Today, we are going to talk to him about the current state of medical education and what the future holds for the next generation of physicians. Welcome, Dr. Lau, and thank you so much for joining us.
It's a pleasure to speak with you, and thank you very much for inviting me.
Thank you. So my first question is, in light of all that is happening in healthcare right now, do men and women, in your opinion, still want to become physicians?
I do think that it's still a very sought after specialty, and the strongest evidence that I can give you to that is that application numbers remain extremely high across the country to become a physician, and application rates for medical school are going in a positive direction.
That's good. And have you seen any major changes in the four-year curriculum of a medical school in the past few years?
Our school went through a major revision in terms of the way that the curriculum was laid out. Before, there would be subjects that were taught in real isolation, but nowadays everything is really integrated into what we call case-based learning, where there's no longer just a separate class for anatomy, a separate class for statistics, a separate class for physiology, but in terms of giving students now, from a very early beginning part of medical school, an actual clinical case that's designed to teach all those threads of anatomy, biochemistry, so on and so forth into one integrated sort of learning style. And so from the very get-go, students are beginning to see how everything fits together for the clinical care of a patient instead of waiting until year 3 or year 4.
And do you think that other universities, other colleges should follow this type of method instead of having the isolated classes and waiting?
I do think that the majority of medical schools are following this type of model. When I was in medical school a long time ago, that was really the norm of the country, but that's no longer, I'd say, the norm anymore. And I think many, many schools are now really using the case-based sort of learning style.
Thank you. In recent weeks, the American Medical Association has taken issue with physicians being called providers. They say that it undermines the ethical obligations, clinical integrity, and professionalism of a doctor. The AMA is also saying that the term provider can reduce the patient-physician relationship to a transaction, and that the term provider does not represent the education and training that the physician receives. In addition, the AMA believes that only allopathic and osteopathic doctors should be known as physicians, and that the term physician should not be used by any other doctor, such as podiatrists and optometrists. I'm curious to know how this has impacted medical education and the way the next generation of physicians is reacting for a call to this change.
I'm not really certain that the topic that you speak of is a real hot button topic on a daily basis here in the medical school. We are really in the business of making sure that we're training students to be the best physicians that they can be, that they have the knowledge to care for anything that comes in through the doors, to take care of patients well. And I think that that's really the focus of what the mission here is in our medical college. I understand why the AMA and other bodies are trying to make this type of distinction. I personally feel that the other types of providers that are out there, I work with them every day. I work with nurse practitioners, I work with physician assistants, and they are such valuable members of the team. In the emergency department that I work, we really see each other as a collaborative effort trying to take care of patients the best ways that we can. I am not a person that really I'm not a person that really is all about titles and about how this person is referred to. I just want to really emphasize that the work that we're doing is very challenging, and without the important contributions of PAs and NPs in my line of work, there's no way that we could take care of patients best. So that's my honest, sincere thoughts about that. And with medical education, I'm trying to show my students about the value of those other people that are working alongside us to help take care of patients. And it's true that our experience levels are all at different there's a different experience level for a physician assistant, there's a different experience level for an NP, and a difference in the training for a physician with medical school and then residency and so on and so forth. But I think to really take care of patients best, there needs to be mutual respect between all those people, and everybody has to have an appreciation for who's got the best skills for the given situation that's on hand. And when people act in that kind of way, free of ego and free of thinking of thumping on their chest about what each person role title is, and so on and so forth, then the best care can be provided to the patient. And that's what we're there for.
Thank you. Um, Going along with physician assistants and nurse practitioners, what is a role that a PA or a CNP will be having as your students begin to practice?
Well, in the emergency department, a PA can go and evaluate a patient, um, put forth a plan, and then we'll usually run that plan through an attending physician provider to make sure that there's proper oversight. For a nurse practitioner, that person can operate really independently without necessarily having an attending physician sign off on every patient case. In the learning environment that this teaching hospital is, I think students are seeing those NPs and those PAs work alongside the physicians that are in the emergency department at any given time. And I think that I work in a very mutually respective and collaborative sort of environment. So I think students are going to see that also. I think that students see the way that we treat each other and the respectful language and the respect for the plans that are, you know, uh, are made forth for the best care of each patient. And I think the students will see and respect that also. I hope that they see the way that I speak with my teammates, and I hope that they take on the way that I carry myself in a professional setting.
Thank you. Um, Striving away from that a little bit, some older patients, when they come to a doctor's office or go to an ER or any hospital setting, they say that bedside manner has changed a little bit, that instead of um, a doctor or a PA or CNP, whoever is taking care of that patient, instead of going up to them, they go right to a computer. They've been seeing that more and more. Um, is bedside manner being taught to today's medical students and residents, or do you think that's something more in the past?
I think, Layla, that it's absolutely something taught here in school, and it's something emphasized from day one. There are dedicated classes to teach students about how do you make a personal interaction with your patient who's a human being, who's coming to you with fear, with concerns, and a lot of times that physician encounter with the patient has got to be has got to be rooted in that interaction, in the social cues and picking up on what the feelings of your patient are. And I make it a huge point to teach my students personally at the bedside about what it's like to make sure that you make that connection. I know we live in a time now in 2026 where personal devices are the norm, where everybody has a cell phone, knows what a computer is, and everybody kind of accepts that the medical record is on a computer. It's no longer paper charts anymore. But, back in the day, there would be physicians, I'm sure, that would focus on writing the patient's chart and they wouldn't necessarily look patients in the eyes. So it has to do with your teachers and it has to do with the way that you are taught and who your mentors are. And I think that at the institution that I work at, we have very strong teachers that are teaching this time-honored tradition of making sure that your bedside manner is tip-top and that you make sure that you take care of your patients and their families first.
Thank you. And going a little bit with that, trust, like that's clearly a big thing between patients and doctors, physicians, everything like that. Is how, in a way, can you teach like trust, if that makes sense?
I think it absolutely makes sense. Trust is something that for some people, you have to earn it. For other people, it's yours from the very beginning of a relationship until you do something to lose it. I think that in building trust with patients, it has to do with first being knowledgeable and showing people that you really do know what you're doing. And that only comes across with experience, that you are going through school, you're going through the rigors of residency, and you can speak in an intelligent fashion to earn that from your patient. But the other aspects of trust are nonverbal. They are absolutely in your body cues. It's, am I leaning forward and talking to you and paying attention to your words? Am I reflecting back on the emotions that I hear that are really clearly in the room without being said? Is it I'm being respectful to you and your family members and calling you an appropriate name, respecting your pronouns, respecting the situation that you're coming to me in that acute moment. Um, it's verbal, it's nonverbal, it's all those things together. But teaching trust is about first making sure that you have the knowledge base to take care of your patient, and then being respectful and having good communicative skills with the patient and the family that's in front of you. I think that's a solid foundation from which trust can form.
Thank you. There's been much discussion in the media and the medical literature about the role of artificial intelligence in medicine, to the point that some are actually suggesting that AI will replace the human doctor. How are medical schools understanding these predictions, and how do you feel about these? Do you think they're true, untrue?
Well, my understanding of AI is really changing every day with every new piece of every new podcast that's put out, every new website that I learn, I try to learn about this and try to keep up to date. But in the first iterations of AI, I understood that it was just a language model where they digested all the information that they could, and then it would just regurgitate information that sounded nice, but it didn't really have capabilities to create novel sort of information. From what I've learned recently, I'm not so sure that that's a static thing and that that's going to be the case. But regardless of that, I don't think that we're at a time and place right now where AI is going to be able to replace human beings for physicians. For all the really insightful questions that you asked me already about trust and about that human bedside manner, there's no way that a robot is going to be able to replicate right now the ability to earn the trust of a patient in an urgent, dire situation and be able to have the outcomes of real medical care that a human being could. A lot of the physician-patient relationship has to do with unspoken things such as body language and trust, because even the very act of giving a patient a diagnosis and giving a patient a plan of what to do, those outcomes of how those antibiotics and how those medications work comes about from the patient's trust in whether the person that prescribed them really knows what's going on. And so if a patient doesn't have that trust in what a AI intelligence is going to say, then I'm not sure they're going to be able to reap those kind of benefits for patient outcomes. Another big thing about AI is going to be that the ability to just digest all the information that's ever been created since the beginning of time. I know that a robot could do that better than a human being, but that kind of humanistic touch, that human ability to come in and allay the fears of a patient in real time, I just don't think technology is at that point right now. And I'm saying this to the future robot overlords that may take over us right now. I ask you to be kind to the human beings, but I just don't think that right now that's a situation that we need to contend with.
Yeah,
And maybe I'm being naive.
I completely agree. I mean, coming from like a patient standpoint, like I get like medical anxiety, so like coming in and just having a physician like come up to me and talk to me, like I think as a patient, like that just relaxes me so much. So I completely agree. Like as of right now, at least, like a robot could never do that. Um, and my last question is, how are medical school professors and mentors viewing the future of medical practice as they prepare their medical students and residents to begin the practice?
I think that we are living in some very difficult times with a lot of ability for people to seek the information they want to find. If you have an opinion about something, there's a community that you could find online that helps echo chamber your thoughts and they just reverberate your thoughts. But despite the very difficult environment in which we are all living in right now, I think that you will find that the majority of teachers at a medical school and certainly at my institution, are feeling optimistic about what the future brings, because we are in a very fortunate position and privileged position to help change what the future will be by teaching in a way that inspires confidence, that inspires positivity, that helps look for humanity, and looks for helping humanity in the very best possible way. So I think we have you as a teacher, you have the ability to influence what's going on now and what happens eons from now, because the lessons that you teach those students will be continuing to reverberate through the future. So I think that if you're in the business of medical education, you have to be an optimist. There's a part of you that has to be that way. And I truly believe that we feel good about the state of medical education and what's to come.
Good. That's amazing to hear. Thank you so much for talking with me today. This has been an amazing conversation. Thank you. I
I'm
am
very grateful for the time.
good. I am Leila Kramer from the National Library of Patient Rights and Advocacy. Thank you so much for joining us.